Welcome. Dr. Tyson and I would like to thank you for taking the time to participate in our podcast today. We're excited that you've decided to learn more about how to give feedback to our learners here at the Baylor College of Medicine. Our objectives for today's talk are to be able to define feedback and evaluation and differentiate the two, as well as to take a look at feedback in medical education and define its role, to think about the reasons we have difficulty giving feedback to our learners, as well as to describe key components in giving effective feedback. So what is feedback? A formal definition is that it's information given during a performance, during that activity, that helps to guide that activity in the future to improve performance. When we look at in the medical context, what is feedback? Edwards et al. In 2002 described it as the purpose of giving data back to the learner for bringing about change. And more specifically in medical education, the component of observation is key, and that informed objective appraisal of observed performance in an attempt to improve clinical skills. So Andy, in his 1983 seminal article on medical feedback, compares learning clinical skills to learning dance. Clinical skill is easier demonstrated than described, and like ballet, is best learned in front of a mirror. So in this case, clinical skills, which are again, like dance, learned through demonstration and performance, and like dance, you need immediate feedback to improve your performance. For ballet, it's a mirror, and for medical education and clinical skills, it's feedback. So how is feedback different from evaluation? Oftentimes these two terms are linked together and intertwined. We almost use them in the same sentence at the same time, but actually they're not synonymous and they're quite different. One way to look at feedback versus evaluation is to think of a cooking analogy. When you're making a soup or making a sauce, feedback is the process by which you're cooking, and during this process you're constantly tasting as you go along, adding spices, thinking about the end product and trying to improve it along the way. The evaluation part of this analogy is that at the end, when you serve the soup or you sit down to eat the pasta sauce, whoever's tasting it has a final idea of what that product tastes like. That's the evaluation. At that point, there's no further improvement of the product. It's the end point. So, in some capacities, it's considered a summative judgment about the overall product. Another way of looking at evaluation, or another definition, is that it's the process of making qualitative judgments or value statements about a person, or it's a collection of measures obtained on that person. And in that capacity, evaluation is more synonymous to grading than feedback. Another way to look at feedback versus evaluation is to compare the two on some basic parameters. When we think about feedback and we think back to our cooking analogy, feedback is done during the process. It's immediate, it's specific, it's timely. And evaluation, again thinking about the cooking analogy, is at the end. So therefore it's delayed and should be scheduled. When we're looking at the purpose of feedback, again it's meant to guide the process, to improve the overall performance. And with evaluation, it's more of a summation of the process. And in our world of medical education, oftentimes a grade. As far as the delivery, once again, it's more about giving information about the process to improve performance, and evaluation is more of a final judgment. And in that way, as far as the grammar that we use, nouns and verbs are used during feedback, and more often than not, adjectives and adverbs are used in evaluation. So during today's talk, we want you to reflect a little bit, now that we've talked a little bit about the difference between feedback and evaluation, to unlink the two. For us as facilitators and educators in medical education, we want to be able to feel comfortable giving feedback and not worry about evaluation. So why do we do it? Why give feedback? Well, all of us want to improve our performance and be the very best physician or researcher we can possibly be. And without feedback, it's impossible to reach our goals. A quote from Westberg and Jason in 1991's paper says, "Trainees don't perform required skills incorrectly on purpose. In fact, errors are usually the result of insufficient feedback. It's not the result typically of a learner not being interested or not being caring about their performance." And another look at it is, without feedback, learners make assumptions about their behavior. Some assume that no news is good news, and therefore incorrect behaviors or skills are reinforced. Good behavior isn't given an opportunity to be reinforced, is the other way to look at it. So learners make assumptions, we can't reinforce good behavior or correct bad behavior, mistakes go uncorrected, and the circle goes on. Why give feedback? It's an important time to give back to the learner. Oftentimes during feedback, learners reflect that they appreciate the attention to their education. So, feedback is good to correct errors and to prevent future errors. It provides an opportunity for our learners to grow and master their clinical skills. It also helps our learners reflect and develop insight into their own behavior and develop their own goals for their education. Schutz et al. In 2004 described all of the preceptor behaviors that most enhanced learning, and feedback was ranked second out of all of those. Again, reinforcing the importance of feedback. Once again, feedback is absolutely essential in clinical medical education. So, if we know feedback's important, we acknowledge how important it is to develop and master clinical skills, why as educators are we failing at feedback? Bing-Yu and Trowbridge in 2009 wrote a commentary in the Journal of American Medical Education about why medical educators may be failing at feedback. There were three broad reasons why they categorized we're not doing as well as we should with feedback. One is that as educators, as physicians and scientists, and as people in general, we have a very poor ability for self-assessment, and the psychological literature supports that we generally overrate our own performances. The second is the overpowering influence of effective reactions. It's uncomfortable to give constructive feedback to learners. We want to be liked. We want our learners to know we like them. And so the effective portion of giving feedback is often a barrier. And the third one, which is why we're here today, is that there's a lack of metacognitive capacities. We simply don't have the skills, perhaps, or the vocabulary to give good feedback. So what are some of the reasons that there are barriers to feedback? Number one, unclear performance expectations. All of us as medical educators receive goals and objectives for rotations and clerkships, but how often do we take the time to clearly study these goals and objectives and really understand what is expected of our learners at the end of our educational encounters? Two is a lack of direct observation, which is a key component. And again, thinking back to the dance analogy, it's very hard to improve a skill without directly observing it. And so direct observation is key, and we have a lot of evidence, especially from the end of graduation AAMC questionnaires, that our learners aren't being observed as much here as at other institutions. The third one, thinking back to the metacognitive deficiencies, perhaps we lack the vocabulary to define or to clearly state learner deficiencies. We sense something is not where we think it should be, but we lack the vocabulary to describe it. And again, the effective portion of this, in that there's a lot of concern about emotional reaction. It's uncomfortable for you as a facilitator or a preceptor to give that feedback, and you don't want your learners also to have an emotional reaction towards you. And one that's often forgotten is a lack of role models. Not a lot of educators take the time to give effective feedback, and as learners, we weren't the recipients of effective feedback, and the cycle goes on. And lastly, but not least, is the lack of incentives. In this day and age where we're under tremendous pressure for clinical productivity, the lack of incentives is often a main barrier. So how do we overcome these barriers? One would be to make sure we understand the learning objectives for our learners. And again, whether they're posted on websites such as Blackboard here at the Baylor College of Medicine, whether they're emailed to you in your inbox, or whether simply asking learners in a self-directed way, what are your objectives for this rotation, outlining clear learning objectives is an important way to break one of the main barriers, which is how to give specific feedback. Observation. Direct observation, as we've mentioned, is a critical component, and taking the time to do that is key. In addition to knowing objectives, so what are you looking for, taking the time to look is important. Again, we need to observe our learners and provide meaningful feedback. One of the ways to be able to give effective feedback is to be able to choose a specific aspect of learner behavior to address. The more broad the deficiency. For example, when observing a clinical student taking a history of present illness, there are many components to HPI that may be a challenge to this learner. However, picking a specific aspect of it to focus on will help you give the feedback as well as it to be received by the learner and to be able to come up with an action plan to improve future behaviors. Vocabulary. As far as overcoming the deficiencies in vocabulary, let's take a look at some examples of vocabulary we've seen on actual evaluation forms here. Keep reading. Great work. Keep doing what you're doing. Progressing well. Very nice to work with. And for those students who bring food during rounds, brought bagels. These are supportive comments, but they're very broad and they're empty. And as far as students being able to accomplish learning objectives, they don't give specific enough information to be able to tackle that. We want to avoid broad, general, empty feedback. One way to develop a vocabulary, aside from learning the goals and objectives for each rotation, is to think about the ACGME core competencies: patient care, professionalism, medical knowledge, systems-based practice, practice-based learning, and interpersonal and communication skills. The Baylor College of Medicine has adopted these 6 core competencies, as well as a 7th in leadership, and also built upon them to develop the core competency graduation goals here for our learners. If you ever need a specific example of a deficiency or to think of wording to talk to a student about, to go back to the CCGG or the core competencies or even the milestones. For example, looking at patient care, you can look at specific examples of behavior that learners should accomplish by the end of graduation. When you see a deficiency, using that specific terminology will help you give feedback to your learners. The next part is the effective portion of giving feedback. Having a difficult conversation and giving constructive criticism or constructive feedback can often be challenging for both learners and faculty. One way to approach this difficult conversation is thinking about useful phrases to help you open the conversation. Some feedback techniques like using the phraseology, "when you said, I was concerned because," or "let's reframe this issue." A very good one is, "let's reflect about what happened." Gives the learner the opportunity to think about and self-reflect and hopefully come up with their own goals for improvement. And lastly, "let's talk about this when the time and the location may be more appropriate." Gives you an opportunity to also go back and reflect and collect your thoughts, maybe review the goals and objectives for the rotation, and to also set aside a time and a learning environment that's safe for your learner to talk about deficiencies. Another technique to approach a difficult conversation or give constructive feedback is the ask, tell, ask technique. As simple as it sounds, number one, asking the learner how he or she thought they did is a very general and open-ended question that allows you to set the tone for what information you're about to deliver. It's also important in that learners tend to identify their own deficiencies. Oftentimes our learners have great insight into their performance and can identify their own deficiencies, which also makes it easier on you delivering the feedback to focus. One open-ended approach might be, how do you think the history-taking portion of the interaction went? And let the learner reflect. Next, you have the opportunity, once the learners discuss what they have done and what they've observed, you tell the learner what you have observed. And again, the tell part is critical because it implies that you've directly observed your learners in this behavior. So for example, tell the learner what you've observed. The questions that you asked were thorough and appropriate for the chief complaint, but you seemed a little uncomfortable asking the questions regarding the patient's sexual history. That sets the tone and the specificity for what you're about to discuss. The last part in ask, which is critical, is ask the learner how you can help them improve. Again, making a self-directed process, allowing the learners to set their own goals, and most importantly, making an action plan so that you as a faculty member can follow up with that learner or tell the learner to follow up in another encounter with another faculty member to focus on their deficiencies. To continue out the example, what can I do to help you feel more comfortable in a situation like that in the future? Some other techniques to think about as far as problem solving, and another way to look at ask, tell, ask, is again to make sure you listen to their feelings and needs, to make this a learner-centered encounter. So asking them how they feel the encounter went, asking them how they're going or what their goals are for the rotation is important. Take the time to summarize their point of view so you make sure you're communicating to reflect back what they've said so you're on the same page. Next, take the time to express your feelings and needs, what you feel the deficiencies are, and hopefully align them with the learners. Next, invite them to brainstorm with you. How can I help you improve your performance? Oftentimes they will have brilliant examples, and oftentimes your expertise will come into play and help them create a plan. Make sure to help write down all ideas without any evaluation or judgment. We're here in a formative way to help guide our learners to improvement, the purpose of feedback. And then lastly, decide together on a plan so that in the future, when you have this encounter again, performance will improve. This is a more prescriptive approach that is taken from the Johns Hopkins School of Medicine. This is what they give their faculty in order to help guide them give feedback. It's a stepwise approach, and for some of us who are struggling with feedback, it's a great tool to use. The first one is preparing before the meeting to set the tone. Be open about feedback. Give feedback in an environment that's safe and quiet and not in front of other learners. To open the meeting effectively, to be able to promote that rapport, and then decide and be very explicit about the purpose of the meeting. And it goes on. So this is available to you through our wiki page, which we'll share with you at the end of the talk. In Medical Teacher in 2012, there was a great paper about giving feedback effectively, and they summed up their 12 tips with the following. As we've mentioned, establishing a respectful learning environment is key. When you give feedback often and regularly, learners aren't threatened by it. And when you take the time and schedule it, again, learners are more receptive, as well as moving it to an environment where it's quiet and where learners have the privacy and are able to discuss their concerns. Make sure to communicate goals and objectives for the feedback. Again, being familiar with the goals and objectives for our learners is key, and also setting the tone for what you're doing and why is important. Oftentimes, using the actual phrase, "I am here to give you feedback," is important. Making sure that you base your feedback on direct observation. Just like being given 2 cakes and being asked which cake tastes better, it's impossible to do so without actually having tasted it. So therefore, direct observation is absolutely critical in being able to give direct feedback. Make sure that it's timely and regular. Again, when you only give feedback when it's critical, learners begin to really cringe when you're asking them to step aside to talk to them. So when feedback is timely and regular, you're reinforcing good behaviors as well as being able to give constructive criticism that's more well received. Make sure you begin the session with the learner's self-assessment. Again, oftentimes our learners have insight into their own performance and are able to discuss what their needs are and help you focus your feedback. Reinforcing correct behaviors is critical. Again, we don't want to be constantly giving constructive feedback. Using specific neutral language is key. When you've observed a performance, you can focus on the performance itself. Making sure not to make it personal is very important. Make sure at the end of the encounter that you confirm the learner's understanding and make sure they understand what the future goals are for improvement of their performance. Concluding with an action plan is also important. So thank you today for taking the time to learn more about how to give our learners feedback. To quickly summarize some of the key pearls we've discussed today, observation is absolutely key. It's key to be able to give our learners specific feedback that will help them improve. Make sure to take the time to familiarize yourself with the goals and objectives of the rotations. Every clerkship director, every program director here at the Baylor College of Medicine, every fellowship director has the goals and objectives for every single rotation for every learner. If you're not familiar with how to obtain those, contacting your clerkship directors and program directors will help you find them. Make sure to schedule the time for feedback. Again, in this day and age of increased pressure for clinical productivity, being able to schedule the time is important to make sure it's done and make sure it's done in an environment that's not threatening for our learners. Again, being able to focus on a specific aspect of the learner's performance. Focus is key, and a specific part of it is key, and observation makes sure that that can happen. Move it to a suitable location that creates a safe learning environment. And again, we've discussed a few of the methods here that can help you, but choose one that works for you and use it continually. We have an outstanding faculty development program here at the Baylor College of Medicine that is nationally recognized. Please make sure to visit the website and learn more about other workshops that can help you expand and improve your teaching and feedback skills. There are many people who've contributed to this talk today from many different schools. A big thanks to all of those from Baylor, Johns Hopkins, Cornell, Dartmouth, and the University of Washington. And last but not least, thank you to Dr. Tyson, who has worked with me closely to develop the content for this material and who was instrumental in the presentation design today. Thanks again so much for learning more about feedback.